All right, sorry. Hi. Whoop. Oh, there we go. I was like, oh gosh, I went frozen for a second, so I apologize. So good afternoon, everybody. Thank you for joining this afternoon's mission or educational series. Today we have Michigan Valley Collaborative joining us. We'll start off hearing from Mark Bradshaw, who's MVC's managing director. He's going to provide us with an overview of Michigan Value Collaborative, and then we will jump into Kim Fox, who's MVC's senior analyst, and she will be sharing some critical access hospital data. Mark, if you want to go ahead and get started.
Great. Thanks, Amanda. So great to be with everybody today. As Amanda mentioned, my name's Mark Bradshaw. I'm MVC's managing director. And joined by my colleague who'll be helping present towards the latter part of our discussion today, MVC Senior Analyst Kim Fox. There's a couple of other MVC folks on the call that you might hear chipping in and out of the discussion as we get rolling. But before we do kick on, I'd just like to thank Amanda and team for inviting us along to present and looking forward to the discussion that we have ahead. In terms of our objectives for today's session, I think we'd like to start by providing a very high-level overview of the Michigan Value Collaborative, just really spelling out who we are, what we do, and how we support hospitals across the state. And you know, we're going to pitch that very much as a high-level introduction, as I said, for those not familiar with MVC. If you are, and you've been participating in MVC for a good few years, I hope it serves as a useful refresher. And in providing this overview, we'll kind of talk through our key analytic offerings, our key engagement activities, and try and provide an insight into what this looks and feels like through our tailored unblinded session, which Kim is going to lead us through. Time allowing, we'd love to kind of round out today's discussion by just hearing from you all and exploring perhaps how we can partner for success moving forward. So with that said, let's kind of jump right into it. All right. Starting from scratch, MVC, our purpose is really to improve the health of Michigan through sustainable high-value healthcare as we work towards that overarching vision of people accessing the right care at the right time, at the right cost. And to do this, we work in collaboration with hospitals and physician organizations across the state, as well as the other 21 collaborative quality initiative programs that you may be familiar with that make up the wider so-called CQI portfolio. And the aim of that collective effort is to really understand variation healthcare utilization and quality, identify, you know, the so-called best practices, and help drive interventions for improving care across the board. For MVC specifically, our work is driven by a team of 20, all of whom are housed at the University of Michigan within Michigan Medicine. So here's the brains behind the operation. And kind of as you'll see on the screen, our team is a mix of clinicians, faculty members at Michigan Medicine. We have analytic claim experts on board, engagement specialists, economists, and a variety of other administrative staff that work together on a daily basis and support our members. This, as I said, is the brains behind the operation, but it's only a real one piece of the puzzle, if you like. Our continued activity, continued success, which, you know, we're collaborative, which is now going on 11 years old, is also highly dependent on our membership and participating sites, which is a nice segue into giving you an idea of what that looks like. So from day one, our bread and butter has always been acute care hospitals. At present, we have around 85 acute care hospital members, which represents the vast majority of those in operation across the state. Over time, I'd say more recently, maybe we're looking at the last kind of 2-3 years, we've worked closely with the Michigan Center for Rural Health to add our critical access hospital members on board. And we have a proportion of those at last count 21 that are currently participating in MVC. And I'll talk about that in a little bit more detail as we go forward. In recognition of our kind of strong hospital facing analytic and engagement infrastructure, We were encouraged to see if we could extend this to the physician organisations in the state. And from 2019 onwards, we took that under our belt, and we now have all 40 physician organisations participating as part of our group. The real benefit of that has been making those connections between physician organisations and their affiliated hospital institutions, and we've been able to play a kind of central role in that engagement activity. For each member that you see detailed on the screen, we have what we call a dedicated site coordinator, site contact. You can think of them, you might have heard clinical champions, quality champions at other collaboratives. We refer to them as site coordinators. It's essentially a point person that receives all MVC outputs, MVC communications, participates in activities. That culminates in about over 150 site coordinators across the collaborative. All this said, I do want to dip into the kind of middle part of the screen, the critical access members, to give you a picture of who's currently on board and who might not yet be part of MVC's collaborative. So the list on the screen, I'll give you a second to take it in while I talk through it. It really represents those critical access hospitals that are part of our membership right now. This simply means you've engaged with MVC at some point, and you've elected a site coordinator at your institutions, for receiving, analytic outputs, engagement invites, any other related communications that are sent your way. If you see your hospital's name on this list, but you're sitting there, you're thinking, who the hell is my site coordinator? It's a natural reaction. Feel free to put it in the chat and we can clarify that for you. If you're also sitting there and thinking, oh, my hospital's not on the list, but either right now I'd like to become part of it, or at the end of this discussion, I'd like to start participating in MVC. Again, please drop your name in the chat and we'll connect the dots. Our engagement team will be in touch to link that up, and we'd love to have you on board. I'm not naive. I know with an open invite of that nature comes the question, what's the catch? How much does it cost? These are questions that I've got over the years. And thankfully, it's an easy one to answer on our side. There is no catch. There is no cost. Participation in MVC is completely voluntary. We are fully funded by Blue Cross Blue Shield of Michigan, which means that any support provided, analytic, engagement, or otherwise, is a free-for-use service for members. Okay, so now we have a picture of who MVC is in terms of our coordinating centre and our membership. I'm just going to pivot and turn towards our areas of expertise. At the core and at the crux of our operation, we really do help members understand their performance using robust multi-payer, customised analytics and at-the-elbow support. Beyond providing that data, we also foster what we like to call a collaborative learning environment, bringing providers, organisations together to learn from one another in a cooperative, non-competitive space. And I think those 2 points speak to the first 2 pillars that you see on this slide in terms of data analytics and benchmarking and engagement and partnership building. Our third area activity, which I'll touch on briefly towards the end of the presentation, is all around our work and support with the other collaborative quality initiatives that I referenced shortly ago. So to paint a better picture of each of these pillars, I'm just going to step through them and give you some context behind each activity area. Okay, so as I just mentioned, one of our core areas of expertise is the provision of robust data analytics, benchmarking intelligence, all of which is underpinned by our existing data portfolio, which you see on the screen. At present, our administrative claims database, so all of MVC's data is administrative claims. We do not abstract any clinical data. There's no requirement on participating sites to contribute data. It's all rooted in administrative claims. And currently it represents around 84% of Michigan's insured population, comprised of 6 distinct payer sources, those being Blue Cross PPO, Blue Cross MA PPO, BCN, BCN, MA HMO, Medicare fee-for-service, and Michigan Medicaid. Each of these data sources does bring its own intricacies, especially with respect to the associated data lag. If you've worked in claims, it's a topic you can't get away from. The real plus is that our Blue Cross and BCN products, we get them directly from Blue Cross on a monthly basis. So they only come with around a 3 to 4 month lag, which is as good as we're going to get it. MVC's Medicare and Medicaid data, we get that from CMS and MDHHS, respectively. And as you know, with those, the lag's slightly longer. That can be anywhere, depending on the day, depending on the month, a 10 to 12 month lag. So worth bearing that in mind as we talk through some of the analytic offerings, the custom analytics. If you're looking at Blue Cross products specifically and you want to dig into that patient population, it's something which can be done with a much more timely look back. With our Medicare and Medicaid data, you're going to have a little bit more of a lag there. Needless to say, our data spans, I think we go back to 2012 at last count. We've typically focused 2015 onwards, and our reports are, maybe within the last 3-4 year time frame to keep things a little bit more relevant. Okay. So that data portfolio, which I just walked through, is then used to create what we call episode-based insights for over 40 different medical and surgical conditions. And I want to paint a picture of what we mean by episode-based insights. Everybody has a slightly different definition when you look across the industry on what an episode grouper is, how it's structured, how it's price standardized, risk adjusted, and so forth. So I'll just paint a very high-level picture of what that looks and feels like. So with each of these data sources that I walk through, we use them to create 30 and 90-day price standardized, risk adjusted episodes of care for those 40 different medical and surgical conditions. We categorize them into kind of 4 high-level buckets that you see on your screen: index event, professional services, post-acute care, readmissions. But within each of these, we subcategorize in order to really help our members identify potential areas for opportunity. And over the years, we've heard, directly from hospitals that they have a real good handle on what happens to patients when they're at their institution. What is a little bit more difficult, and I think we got this sense from talking with Amanda and team as well, is when a patient leaves the hospital's 4 walls. And that's really where MVC's episode-based structure can come into play with that kind of 30 and 90-day runway. We can provide information on, what happened after discharge, where, when, how long for, what payments were associated with said activity. And that really helps fill in that gap. And that's something I'm always keen to emphasize. MVC is not the be-all and end-all data sources. It really should be used as a supplement to the other data that you collect internally, that you use elsewhere, and plug those gaps which we've managed to identify over the years. And hopefully we can maybe have a conversation about what those gaps look and feel like for critical access hospitals towards the end. While I painted a picture of how the data is structured in terms of episode, I kind of quickly glazed over that flagship mention of 40 different medical and surgical conditions. So why don't I just provide a little bit more context around that before I share how you can access all of this value add data. So the graphic on the screen just really presents the top 10 inpatient surgery-based conditions with the highest episode volume across MVC's existing participating critical access hospitals. So those 21 that I showed earlier on in the presentation, these are the episode counts across those 21. Gives you a sense of the most common and what we're able to see in MVC data. No surprise, the vaginal delivery, joint replacement kind of tops the list. We see the other common conditions, which we often talk about, of sepsis, pneumonia, CHF, COPD, all sitting in the top 10. These conditions, which I'm kind of vocalizing, tend to be the ones that are most of interest to our acute care hospitals that we work with over the years. But that's not to say that we're limited to provisioning data on just these 10 that you see on the screen. There are a whole host of others that make up our offering. A full list of those can be found on our website, which we'll provide the link to. Yeah, I think we have a raised hand. I'm happy to take that question just now. Sherry, is that you raising your hand? Do you want to jump in if you can unmute?
Okay, am I unmuted?
Yeah, I can hear you.
Okay, so can you restate this slide we're looking at is specific to critical access hospitals. Is that what I heard you say?
This is specific to the 21 critical access hospitals that are currently members of MVC.
So, and you said it's not surprising, but to me it's surprising because as far as I know, very few of us do vaginal deliveries.
Would
Is that
others, would
surprising
others
to
on the,
anybody else on this call?
yeah, can I invite input from others on the call?
Yeah, Kim, do you want to talk about this? Because we went back and forth on it quite a bit.
Oh,
Yeah.
thank you.
Yeah, Sherry, I'm glad you mentioned that. So when we were looking at this data internally, I went over with Chelsea Pizzo, the manager of analytics, and she was equally shocked by that metric. So we looked at the volume of conditions for the traditional, 30-day episodes at critical access hospital MVC members, and to both of our surprises, vaginal delivery was up, was at the top, and I think it was across maybe, I want to say between 6 to 10 of those hospitals were the only ones that were performing vaginal deliveries. The other hospitals didn't have any.
Okay.
So it wasn't specifically one hospital, but there was maybe like, anywhere from 6 to 8 to 10. I can't remember off the top of my head. We also tried removing transfer cases to see if maybe that had something to contribute to the higher volume, but I don't think you're alone in that. Again, we were also surprised to see that that one up at the top, but I think there are a couple critical access hospitals that do perform those at quite a high volume.
Okay, well, that's helpful. Thank you.
Thanks for your question, Sherry.
Thank you, Kim, for clarifying. And Sherry, maybe that's a point that I can restate. It's representative of the 21, but there may only be a handful of proportion that are represented for each condition, depending on who performs and who doesn't. This is just a count across those that are currently participating.
I don't know if you can see the chat, but for those of you that can't, Megan Mackey just shared that OSF alone performs 300 deliveries per year. So I think that those several hospitals that are kind of the only ones in the region that are available and then doing those vaginal deliveries are making up obviously the largest proportion of those. Thank you, Megan, for sharing.
Yeah, thank you both. Do we have any other pieces in the chat before I perhaps step through our other ED-based episode conditions? Okay, I think we're good. Thank you for the question, Sherry. Okay, so in addition to our so-called kind of traditional episode structure, the MVC Coordinating Centre also recently developed new episodes of care for conditions considered more relevant to the ED. So our ED-based episodes allow us to develop, assess episodes of care for patients who might not otherwise be captured by the inpatient surgery-based episodes that we just looked at, either because they don't have inpatient hospitalizations or because the conditions they seek care for are not as pertinent to an inpatient setting. So when we think about that a little bit more, our index events for MVC's ED episodes are any visit to the ED, irrespective of whether the patient's then admitted as an inpatient or whether they're discharged from home. And our unblinded data session today is actually going to utilize MVC's ED episodes. Spoiler alert, we're going to take a look at chest pain. And we'll have an opportunity to dig a little bit deeper into this data offering later on in the presentation. For now, here's a look at the kind of top 10 ED-based conditions, again with the highest episode volume across those 21 participating critical access hospitals. Again, it may only represent a portion on the count. This list of 10 is fairly coverall of MVC's ED episodes offering. While we have 40 of our surgical conditions, surgical medical conditions, we have a total of around 15 ED-based episode index conditions covered in MVC data, 10 of which you see on the screen. Okay. All right, so that is a picture of our data portfolio and common conditions, common looks in terms of follow-up, readmission, and so forth. Let's talk a little bit about how you can get access to that data if you don't have it already. It's relatively straightforward. As a first step, it's just a case of registering your interest and doing so by emailing the MVC team. You can do that by putting your name in the chat, like I mentioned earlier. Once we get you set up with access, members are able to take advantage of MVC's data registry, which is used to kind of help benchmark care utilization, track trends, identify cost opportunities. I call it a data registry. Simply think of it as an online website that you log in and you can see all the data for your affiliated institution against a number of different benchmarks, whether that be our critical access cohort, whether that be MVC all. We have some geographic regions on there that you can use at your will. There's the opportunity to play around there. You can also export data to use in your internal activities and conversations. On top of that MVC data registry, we also disseminate what we call monthly push reports to members on a variety of topics, and we supplement that with what we call custom analytics. Now, our push reports, like I said, hard copy PDFs, we drop them in a Dropbox folder each month, and you can go in and review them at your leisure and share with other individuals in your organization. Data is also shared at our monthly work groups, and we unblind, like we're going to do today at our semi-annual collaborative meetings, something which become a really core practice of MVC's activity. So let me take a closer look at the benchmarking and the push report aspect, and then I'll talk a little bit about custom analytics. So MVC's push reports, like I said, come out every month. They'll be focused on a specific topic, and the graphics on your screen are lifted from a couple of those that have landed in the Dropbox of MVC's critical access hospital members. The top figure is taken from our recent ED-based episodes push report, and it shows the average risk-adjusted, price-standardized 30-day total episode payments for patients with an ED visit for abdominal pain. There's a title. And it's designed to help members understand where they sit relative to their peers, but also provide that spark of best practice sharing by showing who's at the top and at the lower end when we use these reports to unblind in individual sessions. The lower half of the screen shows two figures taken from MVC's recent Common Conditions report that was shared with critical access hospital members as recently as July of this year. And on this occasion, we've got a snapshot of post-acute care utilization, a trend of post-discharge ED utilization, all amongst patients hospitalized for pneumonia shown. And you'll see some kind of critical access specific comparators to aid benchmarking. That's basically just, you've got your institution's rate, and then you've got the average of the other 20 critical access hospitals participating in MVC shown as well. Okay. So over the years, we've found that once we provide members access to the registry, once we provide these push reports, a number of other questions and opportunities for exploration often come to light. So to help members navigate this, we also offer what we call custom analytics. And it's pretty much what it says in the tin. If you have something you want to look into, just reach out to MVC and we'll build out our report customized to your ask. And I'm just going to step through what that custom analytics process might look like should anyone on the call wish to take advantage of it. So we start with the initial outreach from a member hospital, and then members of our analytic team will meet with representatives from your institution to really discuss project scope. And once we have the specifications nailed down, the MVC team will work in the background on prepping data to answer the problem statement at hand. Fast forward a couple of weeks, completed report is then shared back with your hospital, and we'll schedule additional meetings as required to talk that through and add any additional pieces of data which might be needed. And all that said and done, depending on the scope of the custom request, typically we found them taking anywhere from 3 to 4 weeks. Don't get me wrong, some can be quick wins, low-hanging fruit that take a week. Some can be weeks and months on end. So all depends on the scope of the ask. Okay, so that's pillar one done. If I just quickly run through the other two on our engagement and partnership building first. The various data outputs which I've just talked about, so our registry, our push reports, our unblinded data, and so on, they're only really impactful if they're received and actually utilized by members. So to help facilitate that and make sure members are supported to collaborate and share those so-called best practices, the MVC team provides a number of engagement activities for our hospitals and POs to participate in. And that includes a range of things, virtual and in-person networking events. We have work groups which are designed to bring members together and share insights on dedicated topics, such as cardiac rehab, preoperative testing, health in action. We also hold 2 flagship conferences. We call them collaborative wide meetings, where typically we have around 130, 140 members in attendance. We have guest speakers on specific topics and various breakouts and sessions to allow members to liaise with one another. Outside of those flagship meetings, we do one-on-one site visits with hospitals across the state, whether that be in Detroit or up in Escanaba recently. We're keen to travel all around the state to have that one-on-one time to learn about QI initiatives underway at hospitals, but also to share what we're up to and what might be of use to members, and to pass on what we've learned from other members at separate site visits and interactions. And I spent a little bit of time talking about our online registry. It's not a case of you're provided access and away you go. We do provide some kind of introductory training and then some advanced training as and when users might want to dip into that. I always recommend road testing a few of these. Not every engagement activity, not every analytic output will work for your group, but maybe just pick and choose a few to dip in and out of and see which one fits for you. If you are interested in road testing a few, I'm going to call out a couple. So I think Jessica and Emily will put the link in the chat to our engagement calendar, but just to call out a couple of upcoming ones, if you're old school and want to go pen and paper, on August 13th, we'll be holding a virtual networking event for our MVC members, and that's open to all on the call. And that'll be followed by a dedicated rural health virtual work group on September 26th. Details on our guest speaker to follow. And I mentioned those 2 flagship conferences that we hold. Our next one will be on October 24th, week before Halloween, Livonia, Schoolcraft, if you've been at meetings before there. And again, we'll drop the registration link if you're interested in coming along, and we'll share more details on agenda, speakers, etc. in the coming weeks. Okay, last but not least, our third area of activity relates to our central role in supporting the wider CQI portfolio. There are 21 other CQIs that MVC works with on a daily basis. So chances are, if your hospital participates in one of the other groups that you see on your screen, some of you may not, there might be the opportunity for some coordinated collaboration, some partnership working moving forward. So more just a plug to keep that in mind. If you are interacting with any of these other groups that you see on the screen, we'd be more than happy to explore ways that all groups can partner together for mutual benefit. Okay. So I think I managed to summarize MVC's 11 years of operation in just shy of 30 minutes. So before we move on to the unblinded data, let me just pause. I know that's a quick run through to welcome any other questions on the material that's just covered. So if there's any in the chat, if we can read them out, if anyone wants to unmute and share a question, please do. Okay, Jessica, are we good to move on? Nothing in the chat?
No, I was just double checking. I don't see any direct or group messages.
Okay. Well, we'll put up our contact details at the end. So if there are any questions after the fact that people want to jump in with and send along directly, we're more than happy to answer those, meet one-on-one as well. So right, let's get on to unblinding data. So I mentioned earlier that to come back to a future meeting, or if groups want to meet individually one-on-one and have that discussion, also more than happy to do that. But the question maybe I'll leave the group with is, as you're kind of driving the QI priorities at your institution, time and time again, what kind of data gaps, analytic gaps, resource gaps even do you come up against? and where might, from what the spiel you've heard today, where might MVC plug in and lend a helping hand if it's not doing so already? So I'll maybe leave the group with that. And like I said, if you have thoughts or want to talk it through more, I'm more than happy to meet with anybody, as is the rest of our team. So please do shout. But with that, I think we can safely close for today. I know there's some links and information in the chat, the emails on the screen too, if you're interested in getting in touch. But at this point, I'll probably pass back over to Amanda.
Yes, thank you, Mark and Kim and Jessica and all of those who joined us today from the Michigan Value Collaborative. We are so grateful that you were able to meet with us today and not only provide the group with what you do and how that works, but also giving them an opportunity to see some of that unblinded data and have some thoughtful conversation around that. I will be sending out a survey following the webinar this afternoon, as well as contact information for the Value Collaborative as well. Just want to give anyone an opportunity if they have any other questions before we say goodbye. All right. If not, thanks again for everyone attending. I appreciate everyone jumping on. Again, thank you, MVC. We appreciate all that you've been doing.
All right. Thanks for having us.
Have a great day.
Thank you.